So Kathy, that scenario was very interesting, and so how did it go for you?
It's a little bit harder because it is a simulator, and then because he wasn't responsive, I'm thinking, oh, is it the simulation, or do we not have the verbal in there? But as you said at the beginning, just take it as I assess it. So I assessed that he didn't have any verbal response. I think I did well communicating to him. I wish I had better ability to do my neural assessment. That I'm going to have to go over.
Okay, very good. And I agree. I think that you have demonstrated very good interprofessional or interpersonal communication with him, and then even though he was unconscious, you were talking to him and interacting as if he was conscious, and that's so important. We know that hearing is always the last to go, and so it's very important that we continue that sort of communication with our patient. You did a great job of that.
Good.
And that's really that professionalism piece. So really, that was good. And I think that neuro is always one of the nurses' weakest assessments, and no matter what level of practice you are. So I agree. I think that so I'm glad that you go home and review that, because neuro assessment can be anywhere from the emergency to the wards, any setting. So
Patients have strokes,
exactly.
falls.
Absolutely. So that's a really good point. And so how do you think it went from in terms of your assessment? I know you started to talk about that. You felt that you could be stronger. What elements would you like to be stronger at?
I think the pain reflex, when he didn't respond to my verbal command, I'm wondering if I should have gone more into the Glasgow Coma scale. And usually I carry a cue card. I wish I should have pulled that out.
That's a really good point. Having cue cards is very valuable when you are in situations that you are unfamiliar, if it's the first couple times you're doing a new skill. So I think that's really good. A cue card would be very helpful.
Mm-hmm.
And I think that also applying noxious stimuli is always a source of concern. And again, we call it painful stimuli. Some people call it noxious stimuli. And so a couple of tips that I could perhaps just share would be that you would do your nail, for peripheral painful stimuli, put your pen across the nail bed just like you did. I saw you did a good, and do that at each of those 4 limbs and for about 20 seconds till there's a response.
Oh, 20 seconds.
The other way that I like to apply painful stimuli is actually to do a trapezius squeeze.
Okay.
And so I don't want to do it too hard, but hold that trapezius for about 10 seconds to see if you get a response to central stimuli. Could I please, and again, it's evidence-based, and you can go back to your health assessment text and you can review that, but I discourage using a sternal rub because of our patients having a sternotomy or this may have fractured ribs. So I was glad that you didn't do that. I don't like to see orbital pressure either, or any other kinds of,
especially when he's had a head injury.
Yes, exactly.
I don't want to increase any more pressure.
Exactly. So good. So again, I think you've highlighted some important areas to work on. What did you think about the blood alcohol level when you reviewed the chart initially? What did you think about that?
Well, certainly the accident was probably caused by the fact that he was compromised neurologically because of the high blood alcohol level. And I think ethically, he did this. We have to care for him no matter what. I think that in his rehabilitation, we should certainly look at a consult to assess addictions and that he address that issue. And I think probably the police will be involved too but he'll be charged because of the high alcohol level. But we as caregivers have to provide care no matter what. Their values are different than ours.
Sure, non-judgmental care. And I felt that you were actually displayed that non-judgmental care. So that was really good. And I think that's really good that you're looking at discharge. That's really important in terms of the RN's role is to focus on discharge planning. And so that would be really good. What would you do differently next time you were able to go through this scenario? Would you prioritize differently? Would you?
I think I would do my order different. I think I would focus right in on the neural assessment initially, and then do my vital signs to complement that neural assessment, looking for any changes.
Okay, and had you had the opportunity to check your unit to make sure that you had your suction, your bag valve mask, and that sort of thing? Okay.
And I delayed checking his armband. I should have done that as I came in the room.
Okay.
I think I jumped right into the scenario, and so next time when I greeted the patient, I would verify that, because he's not able to answer either. And many patients answer when you say hello,
Yes, very
even
good.
if they're not that patient.
Very good. So how are you feeling about the scenario after now, as opposed to when you first started it?
I think it's wonderful because it gave me the safe environment to check on him, and I know what I have to look up now, so that I'll be stronger when I go out clinically.
Okay. And so I'm going to ask you to, for next week's class, if you could just write a 1 to 2 page reflection on the scenario, describing how you integrate or how you would integrate evidence-based practice. And so if you could use 3 to 5 scholarly references to support your work, and you can just put that in the electronic mailbox for us. And so just a couple of questions, and I wanted to complete our work here, and I've got some questions that I wanted to address with you. And so what are some of the key priorities of managing a patient with increasing ICP?
Definitely positioned to try and decrease the intracranial pressure. So the reverse Trendelenburg.
30 reverse Trendelenburg.
Looking at his O2 sats, does he need a higher oxygen level? So does oxygen need to be, because we want to keep, with increased intracranial pressure, the pressure then decreases the blood supply to the brain, and we want to make sure that brain is well oxygenated. And certainly the reverse Trendelenburg allows for that pressure to be released.
So the CSF to flow nicely. Okay, great. What about when the family come in and you're doing care? How would you manage that?
I think just explain to them what I'm doing within my scope of practice. And if we need to do more private things, just ask them to leave and go to the coffee shop for a moment. But certainly just so they're aware and that they feel confident in the care that's given in the setting.
And we are giving family-centered, patient-centered care, so that they're an integral part of the team. So I like that. Now, one of the things I want to get at is that part of managing ICP or a patient's experience with seizure would be to provide a quiet environment. How would that change your plan of care?
The overhead light should come on.
Okay.
So reduce lighting, because sometimes lighting can induce a seizure.
Sure.
And the environment, I did remove the pillow, but again, the side rails needed to be up for safety, but we don't want him to, if the seizure was more aggressive, we don't want him to bruise himself.
Sure, so maybe padding the side rails. Okay, so padded side rails. And so what about when the patient experiences a seizure? What would be some key priorities around
airway?
Airway, good. And
so we did position him on his side, and and I removed the pillow so that airway should be naturally open and that secretions could drain. And we did have the suction there available. Okay, that if we needed to suction.
You may even just use the bag valve mask and place that over his face to ensure he gets 100% during the seizure.
Yes,
that might be a way of doing that. Now, what medications are commonly used with a patient experiencing head injury or increasing intracranial pressure? Can you think of any?
The one that comes to mind, and I'll have to look these up, is mannitol.
Okay, so mannitol, so some kind of a diuretic. Good. What other medication?
If they're seizuring, Ativan.
Ativan, good.
Sometimes Valium is used, am I correct?
Yes, absolutely.
Yes.
Valium. I see more Ativan, but Valium or Ativan.
And when I was looking last night, it said that Ativan was safe to use with increased intracranial pressure, but not all medications are.
Yes, good. Is there any other kind of anti-seizure medication or anticonvulsant that might be used in this situation?
If it was long-term, usually your phenobarbital or your dilatins, those sort of things.
So those are things you might want to put on your cue cards and like that. Okay, Kathy, do you have any questions for me about this scenario?
What could I have done better? What did you ask me what I felt? So what do you think I should have done?
Well, and I think that you did a very good job with doing your assessment, your initial assessment, and then when the patient seizure, you called for help, and we were able to position them, and I was able to help you with that. The only thing that, and again, I'm not sure if you had the opportunity to review the chart.